Welcome to Paint Without Poison, as part of International Lead Poisoning Prevention Week, where we explore key issues in medical toxicology and public health. I'm Dr. Jessica Shenoi, and in this episode, we'll discuss lead testing methods, from capillary screening to advanced isotope analysis, highlighting how clinicians and laboratories can select the right tool for the right purpose. Lead exposure remains one of the most preventable environmental health threats, and accurate testing is a cornerstone of prevention, surveillance, and intervention. Today, I'm joined by two of my colleagues, Dr. Anwar Shahin and Dr. Ziad Kazzi. So we'll start with you, Dr. Shahin.
Thank you, Jessica. Hello, everyone. My name is Dr. Anwar Shahin from Başakşehir Çaman Sakura City Hospital in Istanbul, Turkey. I'm emergency medicine consultant and medical toxicologist, also board member of Minotox. Even though major progress has been made in eliminating lead from gasoline, paint, and plumbing, exposure persists, especially in aging housing, imported products, and certain occupations. According to the CDC, any blood lead level at or above 3.5 micrograms per deciliter now meets the blood lead reference value, a threshold that triggers public health action. That's why selecting the correct testing method is critical, not only for diagnosis, but also for environmental source identification and follow-up. Screening usually starts with a capillary blood test, a simple finger stick sample. However, if the result is equal to or greater than 3.5 microgram per deciliter, guidelines require confirmation with a venous sample, since surface contamination can falsely elevate capillary readings. If a venous sample was already drawn for the initial test, clinicians can skip the repeat and move directly to confirmation and management. The take-home point: capillary tests are used for screening, but venous tests are the diagnostic gold standard.
Thank you. So this chart shows the blood lead level in micrograms per deciliters, and then the time to confirmation testing per the CDC. So like Dr. Shahin was saying, if the capillary results are equal to or greater than 3.5 micrograms per deciliter, providers should collect a venous sample. These are the specific types of testing that we'll be going over today and the methods of testing. So let's start with the method many clinicians encounter in the field, the lead care analyzer. This is a point-of-care device cleared under the Clinical Laboratory Improvement Amendments of 1988, meaning it's a CLIA wave test, simple and low risk for operator error. Here's how it works. An electrical potential is applied to collect lead on a sensor. After about 3 minutes, the analyzer measures the amount of lead on that sensor. As I mentioned, per the CLIA Amendment of 1988, wave tests are categorized as simple laboratory examinations and procedures that have an insignificant risk of an erroneous result. The advantages here are the test is very fast. The results are available in 3 minutes, which makes it convenient for community screenings or pediatric offices. The limitations here: it measures only lead, not other metals. Results can be affected by environmental contamination on the skin, and historically, some batches were recalled due to calibration issues, causing falsely low results. For these reasons, it's best used for screening, but any elevated result should be confirmed in a certified laboratory. Another method gaining attention is salivary lead testing. The appeal is obvious. It's non-invasive, low cost, and easier to perform on children. However, studies show the correlation between saliva and blood lead levels is inconsistent, especially at lower exposures. There seems to be a better correlation only when exposures are very high. Because of that, the CDC does not currently recommend salivary testing as a substitute for blood testing. Think of it as a research tool, not a clinical one for now. So, like mentioned, it's easy to obtain from small children, low cost to obtain, but there's an unclear correlation and we need blood confirmation. Now let's move into the laboratory, where confirmatory and quantitative testing happens. We'll be discussing ICP-MS, GFAAS, and isotope analysis. So ICP-MS stands for Inductively Coupled Plasma Mass Spectrometry. It analyzes a lot of elements and can do multiple at once. This is considered the gold standard in modern trace element analysis. The pros: it has the highest analytical accuracy, it can detect multiple metals at once, it requires only a simple sample preparation, and there's a short analysis time. The cons here is that it's expensive, both in equipment and operational cost. It requires multiple high purity gases, and there is a potential for matrix interference. Despite the cost, ICP-MS is invaluable in reference laboratories, occupational health testing, and research on multi-metal exposure. The next method is GFAAS, which stands for Graphite Furnace Atomic Absorption Spectrometry. This is an older but still reliable technology. It uses an electrothermal atomization to detect metals in solution. The way that it works is that there's a metal tube, a sample is inserted, it's heated 3 times, a plume is formed, and then the absorbance is detected at that moment that the atoms are released. The advantages here requires only a small sample volume. It's less expensive than ICP-MS. However, the disadvantages include that it measures only one element at a time, it needs acid digestion sample preparation, and it is subject to matrix effects that can affect accuracy. In practice, GFAAS remains suitable for smaller labs or targeted confirmatory testing where resources are limited. Once a patient's elevated blood lead level is confirmed, the next challenge is identifying the source. Isotope analysis offers a powerful forensic tool by comparing the isotopic ratios of lead in the patient's blood with those found in potential environmental sources like paint, soil, or occupational materials. Investigators can then pinpoint the most likely exposure. Although technically demanding and costly, isotope ratio analysis has been successfully used in environmental investigations, particularly in complex exposure scenarios or legal cases. So testing is just the first step. Once elevated blood lead levels are confirmed, clinicians must transition from diagnosis to intervention. They should report the case to local public authorities, initiate environmental investigation to locate the exposure source, and arrange follow-up testing to track progress. And then, if indicated, consider chelation therapy under expert guidance. Testing should always lead to action, protecting both the individual and their community. So to summarize, use capillary tests for screening and venous samples for confirmation. Lead care is a fast and practical form, but confirm results in a certified lab. Salivary testing remains investigational. ICP-MS and GFAAS are the mainstays of quantitative analysis. And lastly, isotope analysis helps trace the source in complex cases. I'll give it over to Dr. Kazzi now for any last-minute insights.
Thank you, Dr. Shenoi. Thank you, Dr. Shahin, for discussing this important topic. I'm the professor of emergency medicine and medical toxicology at Emory University and the past president of Minatox and the current president of the American College of Medical Toxicology. I've had my own personal experience in these different laboratory methods and wanted to share some thoughts about this. First of all, having the access to the laboratory testing is essential. Many countries around the world do not have these technologies, whether we go from the lead care analyzer to the more sophisticated definitive methods. The beauty of the lead care analyzer is that you're able to, send the machine, ship the machine to a country where this technology is not available, and you're able to also purchase the test kits and perform these easy studies. My first study that was done in the Republic of Georgia in 2015 used the lead care analyzer, and it was an easy way to screen 235 children in a short period of time with a limited budget. However, as you said, this technology is potentially vulnerable to contamination of the skin, contamination of the environment. It does require some training of the staff that will perform these tests and requires calibration. As a matter of fact, my first study in Tbilisi was limited by a recall that happened in the US when the lead care analyzer was reporting inaccurate results. So I had to repeat the study using the lead care analyzer after the recall was over, as well as confirming it with the ICP-MS. So again, sometimes you have some issues running these tests through the point of care test. Now, the preferred method, which is the more definitive method, such as the ICP-MS or the graphite furnace technology, those are more definitive, as you said. And however, they are less available. So we had to ship these samples to the US or to Italy, in our case of Tbilisi, to be able to get these results, which can be a problem or can be difficult. That said, it is the gold standard result. Now, as you mentioned, the ICP-MS will measure a variety of metal alloys in your sample, which can be useful, but also can be a problem, because you'll need to be ready to interpret these results and communicate the meaning of these results to your subjects. And that sometimes is not easy in a research study, or even in a clinical setting. You have to communicate the results to your patients and what they mean, because you will have a variety of metals measured, metalloids, some of which have less clinical significance than others. Finally, the isotope ratio I thought was useful in the case of the Republic of Georgia, as it can potentially point for the source of exposure, which you really highlighted really well, Dr. Shenoi. It's essential to go from a test to an investigation of the source of exposure and potentially treatment, if not only just removal of exposure is sufficient. So I think going from testing to intervention is critical. And again, I thank you for presenting this information. I hope our listeners and viewers benefit from this in this important International Lead Poisoning Prevention Week. And thank you.
Yes, I just want to thank both of you again, Dr. Shahin and Dr. Kazzi, for being here today. For more details, visit the CDC's clinical guidance at cdc.gov/lead-prevention/HCP/clinical-guidance. Thank you for joining us today on our segment on lead testing, and stay tuned for more lead topics this week as part of International Lead Poisoning Prevention Week.